or you
recorded.
have any opinion or question, you just ask. So I have seen this gonna be not very informal, and I'm not gonna go into the detail of the disease. We're gonna go and pick up the abnormalities, and then we're gonna go to the impression and the diagnosis. Why I'm showing you the cases, and I will not see the screen. This the screen that has a lot of people on, so I don't know what is going on there. So I will see only my presentation. So please let me know if my voice is dropping or something, or you cannot see the movie. All right, I'm gonna start now. So all of these cardiac MRI, which we have been doing, these cases are in the past a year or two, pretty new cases. And I will look at the first case. Okay. History of, normally the history is very unuseful. So it's history of ischemic heart disease. And then we did the MR. We normally, this is, as you know, this is like a T2 gradient echo, white blood cine image. So, and I'm gonna go all three, and we'll play a movie, and you can tell me what you see here, and then one more here. Okay. So don't let me only speak. You can interrupt. I don't see your face, so please feel free to speak. This is my two chamber, and this is my left atrium. This is my left atrial appendage. Don't forget to look at it. Sometimes we see clot in it. And this is my aorta. So the two chamber will show you the mitral valve and the anterior wall and the inferior wall. This is going to be LAD distribution. This is the PDA distribution. So this is my four chamber. We have two valve, tricuspid mitral, and we have septal wall and lateral wall. Gonna be LAD and circumflex territory. And it tells you the wall motion. This is my two atria. And this is my three chamber. So you have left atrium, mitral valve, anterior leaflet, posterior leaflet, and you have aortic valve. You have the LAD and circumflex territory here. Okay, my question. Look at the wall motion. Is wall motion normal? You think it's normal? Well, let go or make a comment on any part of the wall motion. I think, let me play this one too. Okay, I think best seen on two chamber and three chamber. The first and the last one. Can anyone pick up wall motion abnormalities here? My anterior wall looks good. My inferior wall looks good. The thing that is not good is not normal. Well, which part is not normal, right? So my is my next question, which is not normal. So if you can see the apex, my apex. So apical hypokinesis or akinesis. So our problem is in the apex. This is a very cool case, I think. It's like 6 months back. And I'm going to go on. We have the stress and the rest. How we do stress? We scan the patient, and then we inject the raquidonazole. And then after that, we inject the contrast right away to get the stress. This is our image. So we normally will get 3 level at the basal segment, and then this is the rest. And then this is the mid cavity of the stress and rest. And then the apical segment of the stress and then rest. So how we already got the stress. And after that, we reverse the patient with aminophylline. After that, wait until the heart rate is back to normal, and then we inject the second dose of contrast. In cardiac imaging, we use double dose contrast. So we inject the second dose of contrast, and then we scan rest. Okay, so now it's different from place to place, but that's how the Wake Forest do it. So I'm gonna the purpose of doing the stress and rest. So we want to compare to see the inducible ischemia. Is there any segment that has inducible ischemia? So this is my basal segment on the stress. And you can look at the basal segment on rest and compare it. See any, normally we look for perfusion defect. Okay, I'm looking at the stress in the mid cavity, and then I'm looking at the rest in the mid cavity. I'm not sure you pick up something or not. Okay, I'm going toward the apex. Stress, rest. So now you can compare the upper row and the lower row images. You can see that there's something really wrong. Is the stress images are normal? No, it's not, right? It's not, which is abnormal here. So it has something, it has a perfusion defect there. On the this one, you see it very obvious, it's the whole thing. So this one has a perfusion defect here. And then when you look at the rest, it's normal. There's nothing there. So you stress the patient. It has ischemia there, but when the patient is in rest state, there's no perfusion defect. The same as this apical segment, it may not be well correlated, but there's nothing there, nothing no perfusion defect in the rest. So for us, this is really important because we consider it inducible ischemia. So those the muscle it can come back after the treatment. Okay, and then we go on to see gadolinium and late gadolinium enhancement. You can see this is the 4-chamber. This is a 3-chamber, and this is 4-chamber, 2-chamber, and 3-chamber. You can normally the myocardium will be this dark like that. Whatever is bright is abnormal, and this is my short axis. You can look at it again. So maybe I cannot make it slower than this because it's come out of the software. So I cannot make it slower, but look for something bright. So my question is, LGE is normal, you think? When you look at it, no, it's not abnormal. So it's not normal. So what is it? See, you start seeing something here. Those are subendocardial enhancement. This one doesn't show much. So the thing is, for cardiac imaging, you cannot look at only one image and you can you tell that there's nothing there. You have to look at them all. Like this one, I cannot pick up anything at all here, but I pick up something here at the apex. And then it's also in this 3-chamber is subendocardial enhancement. The maybe like 50% at the most, for sure is not transmural. And look at the, this is the short axis on subendocardial, on the LGE. You can see there's a whole area segment here, anterior segment, lateral segment, and inferior wall has enhancement, and go all the way this kinds of apical segment going toward the mid cavity. Once you see the muscle, the papillary muscle, you can say that this is in the mid cavity, and also something here too. This is the insertion site. So this one is related like that. So this is the subendocardial enhancement. This one may not, may be different story, but for sure this one is the same story. there is a like extensive subendocardial enhancement here and here and here. Okay, so I show you there, and then the arrow pointing toward the subendocardial enhancement. This one look pretty extensive, almost like more than 50% here. Some of them is about 50, some of them is more than 50. And there's some more here. I magnify it so too much. So whenever in cardiac imaging, whenever you see scar, you have to put first thing first, is ischemic or non-ischemic, right? So for this one is ischemic because it is subendocardial enhancement and it's also along coronary territory here. So what coronary artery territory here? If you look at the 17th segment of AHA, this is gonna be this one is it's going to be mid and distal LAD that has problem because this is the apical segment of the whole thing, almost like this is the LAD. And this is also the LAD. So, but it's not that simple because because you have stress that have perfusion defect, that has perfusion defect, and you have LGE that has a scar here. So this is not just a scar and then let go. This case is really unique. This is an example of infarct with peri-infarct ischemia. Because the extension of this perfusion defect is way more than the infarction here. So actually this area that you see here is inducible ischemia. It's not normal. Part of them, yes, that it has infarction, and part of them, I think it is the infarct with ischemia. So there are two things going on here, not just the usual infarct. How they're gonna do it? This depends on clinical judgment. I leave that up to them. They may go in revascularization because they think that they can recover this part of the heart, or they may just put the patient on medication therapy. That one I don't know in terms of clinical. So this kinds of debating clinical judgment here. So look for, when you have stress, look for the area of a perfusion defect compared to the area of the LGE. If it go together, and also you should see it on the rest, those will be scar. And if it you don't see it's on scar, you don't see it's on rest, but you see it's on stress and LGE, it means that there is additional to that, to the infarction, the patient also have the inducible ischemia in the same segment. Okay, that is a case, one case, very obvious. We have seen a few of these, but this one is very obvious one. So this one is pretty classic here. The patient has heart failure. Look at her two-chamber view. Doesn't look like it moving a lot here. And I have a three-chamber view. You can look at it too. Look at it together here, and the four. Look at them. Very, very sluggish. I would say look like moderate, maybe 35, 40%, at the most 45 around that EF. I'm talking about EF. And then what do we see? And this is my short axis on the basal segment, mid cavity, and apical segment. We'll show you all here. Okay, so wall motion looks pretty very abnormal. It's hypokinetic, right? So EF is about 40%. The calculated EF is about 40%. And my question is, abnormal findings that we see here on these 6 images, this one may not show out very well. We have multi-chamber cardiomegaly. All chambers are big. Look at her chest wall, it's this small, and the heart is so big. And especially these two atrial is really big. The ventricle looks big, but not as much as atrial. And we have concentric hypertrophy of the left ventricle. You see how thick the wall is? The whole thing looks thick, especially here at the septum and at the lateral wall. This is just the tuberculation. Also have impaired EF. We already did the calculation. It's turned out to be 40. What else? We have this one will show you. So we have a little bit of regurgitation in the of mitral valve and of the tricuspid valve. One thing that can have this cause this regurgitation when the heart is big, so the annulus of the mitral and tricuspid valve was pulling apart, so the valve cannot cover the entire area of the valve that is used to, so it has a little bit of regurgitation because of the heart is just so big. Okay, we did T1 mapping. T1 turned out to be 1196 millisecond. We did T2 mapping. T2, this measuring from the mid-septum. T2 is 49 millisecond. Is T1 normal? And the T1 is, this one is not normal. So the normal, this is considered high because normal T1 on 1.5 Tesla scanner, it should be around that, about 950 to 1050, around that. And for the T2, is T2 normal? This one is yes. So it just tells you that there's no myocardial edema. Okay, and the T2, normal T2 is around like 45, 44, 45 to 55, 57, around that. And then look at this one. So this one question is, what is that? If you, I think probably some of our faculty here has told you about this. You see this sequence we call is TI Scout. TI Scout is the sequence that we changing TI time and increasing TI T1 over time to see where is the null point of myocardium, because we want to use that null point to scan the patient. Okay, and if you look at this one, come with me. Okay, see that my myocardium and blood pool with the same color. And I'm going toward TI time is higher. You try to find the null point of the myocardium. The means that the myocardium is all black, so you choose that point. Seems like this case, you see, this one, I'm having trouble with finding the null point because they look all like hyper signal all every time from here to here. Normally, when the blood pool is getting brighter, the myocardium should get darker. But the myocardium in this case is not getting darker. So now we have difficulty nulling problem here. And then we did, the patient have breathing motion artifact. We cannot get a good images here, but we can see something here from these two chamber. If you remember the case before, how nice looking the myocardium should be, but this one is not. You see that how like, wow, the whole thing has enhancement, the whole thing. This one is a bit harder because we can't see the posterior wall here, but the anterior wall look a bit funny here. And this one is the four chamber, the whole thing as enhancement. So this is the transmural enhancement. So for transmural, we can see transmural in ischemic heart disease as well. And look at our chart axis on LGE. I'm going to go from the basal segment. See my myocardium here is very bright. So part of it is kind of trying to be normal here, but most of the myocardium are not normal. If you look at this, like this one is probably normal myocardium, but this one may not. But if you go further, this one is not, right? So there's like a big segment of transmural enhancement. LGE is normal or not? The answer is not. And so again, I always come to this. Is it ischemic or non-ischemic? For the ischemic, very easy, subendocardial enhancement or transmural enhancement and following coronary artery territory. Okay, and this one is we have transmural enhancement. Yes, it could be ischemic, but you cannot explain by coronary artery distribution. So from pattern with the from that pattern is right, but the distribution is not right. So this one will be a non-ischemic. So we calculate extracellular volume. Extracellular volume is considered high because it's up to 87%, and normal extracellular volume is about 25 to 39%. How we do it? We used native T1 and the blood pool. The number got from the native T1 and the blood pool. We use hematocrit and post GAT T1 of the myocardium and the blood pool, and then we put it in the table in the calculation in the formula. It turned out to be that it just tells you that there is a lot of extracellular space or there are a lot of scar here. So this person has concentric thickening, low EF, high native T1, high ECV, difficulty nulling, transmural enhancement. This is amyloid. Very slam dunk amyloid case here. Yeah. It's maybe in the board exam, I think, because it's really classic. And amyloid has another pattern. Another pattern, who knows what's another pattern of amyloid is? It's going to be subendocardial enhancement. So amyloid and ischemic heart has similar pattern, but coronary artery distribution will belong to the ischemic heart, but not amyloid. Okay, this person after this CT, after this cardiac MR, he went on to do this, to do a pyrophosphate scan for amyloid, and this is how it looked like. This uptake, the whole thing is uptake here. So there's diffusely increased uptake throughout the myocardium here, and this is from the read from a NUC people. Is ATTR cardiac amyloidosis. So amyloid has two patterns, is light chain and ATTR. We cannot, there is no tracer for the light chain, but there is a tracer for ATTR. So but the light chain is easy. You can work up like blood work or bone marrow biopsy, aspiration biopsy, you know that. But the these two has different treatment. One will go to stem cell transplant, and one will go to chemotherapy. So there are different type of amyloid here. If once when we are at the end of the cardiac imaging, we always say, okay, let's do PET-CT, and they will continue to PET-CT to be able to tell this is ATTR type or this is the light chain type. Okay, so this is an example of cardiac amyloidosis. Okay, chest pain. T2 gradient echo, white blood, cine imaging. Two chamber, three chamber, four chamber. This case, I remember it was like last 2 months. Okay. Looks pretty good to me. This is not a good view of it because we see too much pulmonary artery, but it's okay. We see also the aortic sinus here too. Okay. And this is the short axis on at the basal segment, at the mid cavity, and at the apical segment. Okay. Question is, looks normal, right? But the patient has had chest pain. and actually has a high troponin. Okay, is the wall normal? I think it's normal. The function looks so good here. He's a young person. And you notice something here? Very, very minor thing. Look at that. See that? See my mitral valve regurgitation a little bit here? Okay. All right. This is my LGE. This is your nice looking myocardium here. This is nice looking myocardium. We don't see much here, right? On the 3, but on the 2, we see something, no? Like that, right? And maybe something here on the, this is 4 chamber, sorry. On the, sorry? 2 chamber, we also see the same, we see that this look like so transmural. Like when we talk transmural, we always talk like amyloid or ischemic heart, right? Let's look at this. Look at the chart. Very nice looking. This one nice looking myocardium, nah? Right? And then I'm gonna continue. This one is the same one that we are seeing here, right there, right there. So it's one is a lateral wall and one is an inferior wall. Okay, so we see a few things here, and then LGE is normal or not? We can answer that it's not normal, but because we see this, something like this like in the chart. We see it here. Yeah. So this is not normal. So question, this is transmural. So is it ischemic or non-ischemic? It can go either way. If we see only that one little thing here, it could be scat, or it could be small embolic embolus thrown into the distal branch of the diagonal branch and can cause that, or OM branch and can cause that. It could be scat, but look at this. Second look. We also have this in the inferior wall, which is this one. So now it's not, something is weird here. It's not along the coronary artery territory anymore. So from initial thought that we think that is maybe a scat, spontaneous coronary artery dissection. That is in a female, young female with chest pain, may have fibromuscular dysplasia, may not. And so since we see 2 spots of LG here, so it's non-ischemic, okay? And this one is the short axis cine. We don't plan to do this, but at Wake Forest, you see the intensity of the signal intensity of myocardium is look a little bit on the bright side because we inject the contrast and then we have to wait 8 minutes before we do the LGE. So we have 8 minute time in that period. So we just go back and do the axial short axis. The contrast is already in the patient. So the myocardium is start taking up the contrast. I should not say myocardium. The contrast is extracellular space. So contrast is start distributing within the extracellular space in the myocardium. And this is right after we inject. So it's within the first 2 minutes. You see something here? This is really interesting here. You see bright signal here? That is exactly the same area here, like we see on your left hand corner here. So it tells us that the patient has a hyperemia. In the first 2 minutes, we still can see the contrast is taking, is bright, the signal is higher here. So tell us the patient has hyperemia. What does it mean? It's acute. Okay, and we go on and did T1 mapping. T1 mapping in that area is 12, 19. This is high. We did T2 mapping, T2 exactly the same spot here. I did exactly the same spot here. It's 75. ECV is 67. That's way, way high. And that's focally increased ECV. The whole thing, if you do calculate from here, is normal. But if you calculate from the area that has enhancement, is abnormal. Have active myocardial edema. This is T2 is high, means that the patient have edema, and this is like a increase in the extracellular space of the high ECV here. So if don't count clinical context here, the differential diagnosis like this is going to be myocarditis or sarcoid. And the patient plus clinical context of this patient, which is a young patient and is a man. So this turned out to be myocarditis. It's not sarcoid. His lung is fine. His lung is fine. Normally sarcoid, it involves lung, and then we'll see cardiac fibrillation. I'm sorry. Do you see my screen? Or I'm talking to myself here?
That's well seen.
Yes, yes.
Okay. Let me go. So that one is the acute myocarditis. What you will see is that is Lake Louise criteria 2018. That is the newest one. Yeah, we use that. So you see T1 high, that's good. T1 native, T1 ECV is high, is good. T2 high. What else? The function may be normal because it's only very focal here. All of these will increase the diagnostic accuracy of the acute myocarditis. T1 high, T2 high, ECV high, and hyperemia. That is a good sign. The patient has active myocarditis and has hyperemia is better than not having active hyperemia, because when they follow the patient without hyperemia, those will do worse than the one that has hyperemia. So to me, it kind of your body react to the inflammation. The more inflamed you react, it means that you have good immune response. That's just my thought. Okay, and we'll do the next one.
Sorry, what is against being an isolated, being two focal lesions? What is against being sarcoid?
Oh, you know the history. This one helped us a lot because he's so young, and he did not recall the history of having a cold or anything in the past. And he says because of the young age and this the gender, and the symptom is just very classic. If we cannot differentiate these two, I think it's going to go into the cardiology group to see that what they're going to handle. But most of the time, when we read something like this, we are actually a cardiac imaging team. So radiologists read it and then cardiology read it. When I have questions, I will call them and ask. Sometimes they call me and ask. So we always, and it is their patient. So our thought is always like go together in the same route. If you are not sure, I have a solution. Sometimes I don't know what I'm looking at, and I've noticed something there which I'm not sure is real, is not real. One of the senior colleague here, cardiology colleague, he always tell me, "Hey Nat, you just get follow up 6 months." Yeah, that's what I normally do if I'm not sure about something. But this one, we both cardiology and radiology agree that it is likely myocarditis. I'm not sure I'm answering your question or not, but if you are not sure, you can go back and dig into like a CT, prior CT or history of sarcoid. People were saying that we get more isolated cardiac sarcoid, but in reality, I'm not sure that, because we see it like little scar. We really don't know what's wrong with this person in the past. Does he used to have URI and have a myocarditis at one point, and then it's where the scar is left over, or he start having sarcoid? That one, I don't. I think we just see cross sectional of the whole thing, and we cannot tell. If we can tell, like this case, if you have a big lymph node, you probably go by sarcoid. Yeah, but if I don't have big lymph node, I put two things together, and then at the end I said, comma, favored what? So I just put that in. I'm not sure I'm
I
answering.
agree, Nat. Yeah, that's the way you have to approach it most of the time.
Yes, yes. Thank you, thank you.
This is just a question regarding that. Is there a role of doing a PET-CT just to differentiate between cardiac sarcoidosis and myocarditis, particularly when there is so focal enhancement, kind of a nodal like in this patient?
I think in some selected cases we do, but you know what? Honestly, I've been here for like 4 years, but I have never suggest the clinician to go ahead and do cardiac or do the nuclear medicine to rule out sarcoid. But I have seen scattered cases. It's pretty sporadic cases that we did for the sarcoid, and most of those are negative. Most of those are negative. I think there's nothing wrong to ask for it.
Yeah, I'm
You know.
not sure. Does anyone on this know if there's literature to favor like FDG cardiac PET findings of sarcoid over myocarditis? I feel like they would both be metabolically active.
Mm, you know, if um, the active process of, to me, I'm not sure, correct me if I'm wrong, I feel like the myocarditis is something come quick and go quick. If the in the active phase, you see it, do we see that maybe it's the same uptake, but inflammation, but later on, it should be, for myocarditis, should be like down quicker than sarcoid. Sarcoid to me is like long-standing disease. I'm not sure. I have no I have not read about the NUC. Thank you for your input. I like that. Thank
Oh
you,
yeah, very good.
thank you. Okay, next one. We have, history is not really useful here. So let's just say a cardiomyopathy. Okay, and then this is my four chamber. Sorry, the chart axis on the. I'm gonna play movie all here. And okay. Question: while motion, is it normal? Maybe like 50% EF. I'm guessing. Yeah, I always guess before I do the calculation. It's just make my day much more a little bit fun. So I think that there is a little bit of hypokinesis. If you look at it carefully, look at the inferior wall. This not much here, but when you see it on the chart axis, I think how I do it, I use my pen and I section the ventricle into a quarter, and then I just use to see that how it's moved into the center of my pen. Like I will put my pen here, and then I see how it's squeezed in and out. Is the same? Like this one, I feel like the inferior wall look a little bit hypokinetic, especially in the mid cavity. The apical segment is okay. Basal segment maybe a little bit, but this one is definitely abnormal. This one is a bit hypokinetic. Okay, and then we did again TI scout. So we are looking for the null point. Excuse me. Null point of myocardium. See, whenever the contrast in the myocardium is bright, the muscle should be dark like that. So the null point is somewhere here. I like it here. So I'm going to pick that number from the scanner, and then I will scan the patient. Some recommend to increase 10 milliseconds, some will not. It depends on the scanner. A Siemens that we use, Alvanto, it suggested us increase 10 more milliseconds. So we did that. And this is my three-chamber view. This is my two-chamber view. This is my four-chamber view. And this is my chart axis. Okay, I'm going to keep playing. You see it? Oh, okay. All right. Playing. Okay. The question is LGE normal? Everyone know that it's not. The normal one is here, right? This one is nice and dark. You even can see something from the TI scout here, actually. And it's not normal because that area is abnormal. And you also see it on the two chamber in the inferior wall. The inferior wall that we have question with, that is hypokinesis. The wall thickness looks normal. And then we have a little bit at the basal septum. And this, even on TI scout, we pick up something here because it has no enhancement. Sorry, it's not dark, not has no enhancement. It's not dark like a normal myocardium, but it should be null. And then, right. So now come to the same concept. Is ischemic or non-ischemic? So this look like maybe ischemic. It look like the whole thing is gone. You cannot identify the muscle at all. When you're not sure that the whole segment of the muscle is gone or not, pull up the pre-contrast. Exactly the same view. Like if you look at this on three-chamber view here, pull three-chamber view right up to it, next to it, so you can see that the whole thing is gone or not. Has to be at the same level. Okay, and then this, we already see that, right? Okay, I'm gonna go to here. I'm gonna stop there. So not just that, this is a bit complex. We have that, we showed you before, but we still have something here. Look at this, the thing, little filling defect or something here inside that area. Now, it's the same here, and there's a little thing here that inside the transmural enhancement. And if you look at, I just focus on the short axis, see, and we have that thing. So you can see that there is a big transmural enhancement in the inferior wall. There is some area of non-enhancement in the middle. This, if you look back at the four chamber here on non-contrast, let me go back. There's nothing there. It looks normal. So it means that the whole thing is the LV myocardium that has a problem. It's not thinning or anything here. Okay. So my question is this event acute or chronic? Yeah. And it is acute because this is microvascular obstruction. We always see microvascular obstruction in acute event, acute infarct. But microvascular obstruction can persist up to weeks or sometimes a few months after the first we saw it, after the patient first got into the patient. First we see him or her. Okay, this is microvascular obstruction, always acute. And then what is coronary artery distribution? So this is in the inferior wall. So it is the RCA, right? And this is really, I really like this case because of this. Notice something? Ta-da, here. You have right ventricular infarction. This is my second case that I saw right ventricular infarction from the RCA infarct. But the infarction of the right ventricle has better prognosis than the infarction of the left ventricle. So it eventually is gone somehow. Very cool case. I really like this LV infarction here. And I think I have, just right time. Okay. 2 chamber, 3 chamber, 4, 3, and 2. Okay. You notice we talk about this. Look at my myocardial signal intensity here and here. Is a brighter because here we did it after contrast to save some time. So we don't have to wait 8 minutes. Well, function look a bit on the low side or normal. Normal. Otherwise, everything else to me looks a little bit hypokinesis. Don't remember how high, how low. Okay, this is my TI Scout. Let's see, do we see difficulty nulling or not? See, myocardial is bright, blood pool is dark. Now switch. Myocardial is dark, now the blood pool is bright. That is the way it should be. Not like the amyloid case. No? And then this is this is a cool case. This is 2 years 2 years ago. I remember this one. And this is the 3 chamber. This is the 4 chamber. This is 2 chamber. That may not so. And this is my chart. Okay. All right. Let me do it again. The answer, I think the money is in the chart axis. All right. Okay. Right, that is cool. Because we don't here, we see subendocardial enhancement. Right here. So when we see subendocardial enhancement, okay, is it ischemic heart? Is it amyloid? Right. So this one, the heart looks a little bit on the big side. When you look back here, maybe something here, or maybe don't even see anything much here. Okay. Actually, is normal or not? No, it's not normal because it's had the very extensive subendocardial enhancement in the basal to the mid inferoseptal, inferior, and inferolateral wall here. And it's just a little bit here, like there. So that is the, and sorry, that one. That one is this one, the anterior wall. So again, it's the lower one is trying to be coronary artery distribution, but it just start getting something wrong in the anterior wall. So from here, we can tell that this is non-ischemic. It's not along coronary artery distribution. Okay, this is a 25 years old woman come in with pneumonia. And this is her chest radiograph. And she was in the hospital for a week, and then she suddenly have heart failure. So that's why we did cardiac MRI. So that is her, she has pneumonia here. Everyone will read this out, pneumonia, big heart, or aspiration. And then when we did CT was done a few days later. It's a cool CT too. I did not look at this until I look at the MR first, and then I go back and look at her CR and her CT. Look at her CT. Don't forget, 25 years old. Okay.
Is this going to be IgE related?
I'm sorry,
Oh, hi, Nat.
Yes?
Is this going to be like IgE related?
Oh, this one, my thought, I'm not sure. She does not have that history.
Oh, okay.
She's not a healthy person, but what I can catch from here is this. You see?
Yeah.
I see like, hi, is that ATO? Is that organizing pneumonia look to it? Not just one, we see right on the left. And then I just go right. Whoop.
Oh, I said IgE. I meant eosinophilic. The letter E is in my mind. Sorry.
So this is a very good example of eosinophilic endocarditis.
Yeah.
He has high hemophilia. I really like this case very much.
That's so cool.
Very cool case, right? Yeah. And she make it out of the hospital, and we still following her up. Yeah, that was 2 years back. She was so bad at the time. I was afraid that she's gonna make it out, out of the hospital or not, but she did, and she came back for a follow-up. Okay, this also the subendocardial enhancement also see in eosinophilic endocarditis. So think about that. That's all in the differential diagnosis. And this one, the patient is so young. It's not gonna have ischemic heart at 25 years old. Yeah. Okay. All right. Oh, right. This is the last one. Won't take much time here. To chamber, 4 chamber, 3 chamber. Okay, I show you all here. So look at the wall motion. I would say looks okay. Looks normal. There's nothing wrong here. Wall motion, no, yes, wall motion is normal. Okay. All right, so we did TI scout. Again, don't look at when the blood pool is dark, the myocardial will bright, and the blood pool is bright, myocardial will dark. This is nice, perfect looking TI, good TI scout. I'm gonna pick it here, pick TI time here to scan the patient. And this is my CT, my LGE. This is the patient cannot hold the breath very well, so but there's nothing really focal except that little bit of inferior wall insertion site that has a little enhancement, which is really non-specific, like that. It's really non-specific. Or if someone did not pick that up or ignore it, it's perfectly fine with me. So I think there is a little bit of insertion site fibrosis. Okay, this is the thing. We did this. I have noticed we did both because I asked, normally technologists will not do this. They will do only this. Okay. And I asked our technologists, oh, can I add this in? So since then, they added in. What technique are we using here? So the first, on your left, the patient has median sotomy here. We call it tagging technique. On your right, we call it free breathing. So what is the purpose, or what are purposes of this technique? Yeah. Okay, I'm gonna come back here. Look at my tagging. So this pretty, so what we are looking for here is constrictive pericarditis. The patient has history of a pericarditis before, and that's why we are doing this. Okay, look at this with me. Okay, when you look at the line, Tiny, when you look at the line, you see, I'm gonna stop. This line passing, this is my pericardium. This is my pericardium. I'm gonna keep my eyes on this. This is pericardium here. And those lines of pericardium, there are two lines, two layers, not two lines, two layers. There are visceral, this is serous pericardium. There's a visceral pericardium and parietal pericardium. In between, there is a pericardial fluid to prevent friction between the layer. Now, in normal heart, your pericardium, visceral and parietal pericardium will slide on top each other. So the line will break. The line will break, like break apart. But once you have pericarditis, the line will not break. Does it make sense here? That's how we radiologists like tagging, cardiologists like free breathing. I have noticed that. But they look at this thing too. They were asking me, why are you doing this? Why you do this, that tagging thing? I said, okay, it's about that. It's about the pericardium stick together. So if the breaking line is considered normal, if it's not breaking, like this case, it's not normal. You can follow your lines here. It's not breaking, really. Okay, now what about this? Look at the interventricular septum. The patient is breathing in and out, in and out. We let the patient breathe freely, and then we just start scanning. Look at the interventricular septum. It looks okay, right? But part of it is not okay. Yeah, look at that. See that? It's flattening. And then otherwise, it looks otherwise fine, but it's part of it. Just the early inspiration, if you see flattening of interventricular septum during the inspiration, that tells you that the patient has pericarditis because of the pericardium is just so stiff and the heart cannot expand. You probably have to go in and read about the ventricular interdependence to read about physiology of this. So just I digest it, and then I just remember that inspiration and then your flattening, your interventricular is flattening, is constrictive pericarditis. So these are two things that we do with the, okay, I showed you here too. Okay, it's flattening. Yes, done. You have any question for me at all? I like these cases. I really like them.
Wonderful cases, Nat. Thank you so much for doing this.
Thank you, Joe, that inviting me to
Of
make
course.
this. Thank you. Thank you. We'll see you next time.